This next talk, I just wanted to, for people in the room, again, if you work with an athletic population, people got to go back to some type of strength and conditioning. They got to be in a weight room at some point. What I wanted to do is show you this video. When I talked, I didn't include this one last time, but again, it's a what I do to start people. Again, they go in side plank, short leg position. They'll do leg raises. Then I'll have them go clamshells, again, making sure that the pelvis isn't moving. But this way I'm getting frontal plane, I'm getting transverse plane. Then I have them go sagittal plane, where they'll just do running motion. But it's a nice way to get the core activated in every position. Again, so we just start with 5 or 10 leg raises, especially in the beginning because they can't support the long lever arm as much. Then right into clamshells, transverse. And then lastly is just running form. And I'll have them do 5 of these so they get sagittal, making sure their pelvis isn't moving. Okay. For activation, what I usually do in the beginning for these people is I start with this, and then the second thing we go to is in a sagittal plane, we'll end up doing stir the pot, both directions. We end up going from stir the pot in both directions to, we do it in a hover position. We don't do it in a plank position either, so that they're in a more of a hover position. Then they do stay ball rollouts, and then they do just hover on the ball where they go down and almost touch their knees. Then we have them roll out onto the ball. They do push-ups and then pikes on the ball. And then we have them go to the wall next, and they do the wall press against the wall. So the running man, where they're pushing against the wall on that leg, have them do 5 to 7 of those. Then we have them do bird dogs, and then we'll have them do in front of the cable columns where they do double cable crossovers where they come up out of it. That way I get core, I get hips, and then usually to end I'll just have them do a 3-point step with a band. They do all of those things. I know that the muscles are on in almost every plane. For people that don't see a lot of athletes, think of it this way, even though this talk, it has a lot of applications. If you look at squats, they're basically transfers. If you look at lunge, it's stepping up a curb or onto a box. If you look at deadlift, it's bending to lift a child. If you look at hitting, it's reaching and turning. If you look at throwing, it's rolling. If you look at kicking, it's going upstairs. And if you look at cutting, it's like turning a corner. So it has ADL applications, even though most of it is based from a weight room standpoint. Dr. Noah already covered this about the osteoarthritis, Reinhold Gons's paper in 2003. Some interesting things to point out is when you look at Contact Forces, Journal of Biomechanics, stair ascent and descent, as Phil already pointed out, it's going to be somewhere around 3 times body weight, maybe a little bit more. Newman and Cook in 1985, Phil talked about the cane and carrying a load. The other thing that was shown is that if you carry a weight, let's say you have a 5-pound weight in your right hand. If you increase that 5-pound weight to 10 pounds, the activation of the glute on the opposite side will be 3 times as much. So doubling the weight and doubling the resistance on the contralateral side will cause an increase of contralateral glute med firing by 3 times as much. Okay? The other things are, remember the gender differences exist between males and females. Joint loading magnitude is different because femoral head size, which is approximately 30% less in women, and ground reaction forces act primarily in the upper quadrant of the femoral head. Where do we see most of those labral tears? It's in that area. So again, it has some relevance. If we look at the OA patients that exists, Patients presented with weakness of all hip muscles except for internal rotation and extension. And you could see right there that there were reductions as people start to get arthritic change. Part of it is probably because the muscle starts to shut down. It doesn't want those compressive joint forces taking place. Fundamental skills, remember in sport you got running, jumping, landing, throwing, cutting, and squatting. APTA put out a hip monograph, one of those monograph series, and we did, I did one of the chapters in it, one of the monographs, and they had 6 of them in it. It went from early developmental stuff to hip rehab to mechanical stuff, biomechanics, and Phil did a chapter in that too as well. And so it's actually a nice read. It has a lot of references, and it's through APTA. If we look at over coverage, under coverage, just not to reiterate it too much more, but basically remember what you got here is you've got anaversion, you've got coccyvalgia, and you've got dysplasia. Remember on the bottom you've got a big cam right there on the femoral side. You've got a pincer or rim lesion. Remember, every step we take, something happens from the ground up. If we look at what happens with excessive subtalar pronation, you get lower extremity, internal rotation, and inferior drop. You get increased tensile strain of the iliopsoas and piriformis, narrowing a greater sciatic notch, predisposing entrapment. The body of L5 rotates to the functionally shortened leg. Lumbar spine tries to straighten by laterally flexing towards the long leg, and you get discompression and facet joint hyperextension. So if we think of that, every step that you take, imagine that's with a normal person. Imagine people that have pathology and how they compensate, whether it be at the foot, the knee, the hip, the back. So your body has to be prepared to at least manage and control those forces that take place with just normal gait patterns. If we look at throwing, again, when I was at the University of Pittsburgh Medical Center in the neuromuscular research lab, there was a guy named Scott Lephart. So whenever we had athletes that got injured, we'd bring them in, and we looked at throwing, we looked at baseball hitting, golf swing, and martial arts. And if we look at this motion right here, this is a thrower. So you could see that on that front leg, what they do is they're open chain. So you got femur on acetabulum, the back one, and you go closed chain on the front now. You got acetabulum on femur. So again, it's a combination of both, but being involved in function, we see a lot more of acetabulum on femur, and that's why the core is so important, because that's where we're going to get the control. And then on the hip side, Phil showed this morning that when you carry that stuff, if the pelvis goes up because of the load on the opposite side, that glute has to work that much harder on that side to help pull that pelvis down to keep it level. So again, just something that we see. If we look at it from the front and the throwing motion, you could see comes forward, foot goes on the ground, and then rotates over the top of the femur. One thing that you'll see is if people that do have impingement, whether it be golf, whether it be hitting, whether it be a baseball pitcher, if they have pain, and older people too, even if they have degenerative joint disease, what happens is if they golf and they want to play golf and it's not like any big deal what their score is as much as it is to have fun going out, just turn their feet out a little bit and they'll be fine. They may have a little bit of less of a performance or how far they could hit the ball because they can't post against a good front side, but again, they'll be out of pain and they'll be playing fine. If we look at kinetic linking escape routes, you could see here running, this was the guy that was the football player that was rotating to his opposite side to make a catch. And you could see how his foot turns out on that right side, and it's almost like you get some rear foot eversion there when he's running. So again, if he had subtalar issues as well, if he had ankle issues as well, and trying to get dorsiflexion, we had to watch for all of this that took place when we started him running. If we look at hitting and the forces that take place, This was a paper I was part of in like 1995, but we looked at about 30 baseball players. This was for the old Montreal Expos teams. And what we saw, and what you got to just remember from this is the velocities and all don't mean as much as this. If you have somebody that plays baseball, when you take the bat back to get ready to coil, you're going to have about 100% of your body weight in the rear leg. The front leg, you're going to have about 125% body weight. So if it's a rear leg versus a front leg, you got to be thinking that you're going to have to put more force through that front leg, and so that might take an extra week or two to get that person back. The big thing to take away from that. If we look at results in 1993 paper, hitting is a sequence coordinated activity and everything starts from the ground up. If we look at hitting exercises of choice, I love this instant replay because what you do is you could work internal and external rotation, you get iso-econcentric, and we've got a trunk exercise where we're doing lifts. I can do lifts in a long lever arm position, or I could do it where he pulls to his chest and then turns and pushes away. So short lever arm, long lever arm, and then remember this one, that's the Heisman. So you bring your leg up and across. So those three exercises work pretty good with hitting people. Force is acting on the hip and pelvis. It's important to remember that compressive load of 115% body weight at the pubis, beginning of swing phase of when people move. The two papers down below, Katie in 2006, found a break point for hip abductor strength was at about 30 max efforts. So if you're doing a lot more, than 30 reps for the adductors, that might be the ceiling before those muscles start to fatigue a little bit. Bazkowski showed they took Australian rules football players, and basically they took MRIs before and after them doing 100 kicks. And the adductor longus and the gracilis had signal changes in the MRIs following 100 kicks by 30% and 49% for those two muscles. So if we think of kicking and we talk about the psoas and the strong hip flexors, the quad, but then we see that the adductor longus also and the gracilis, which are adductors, had these signal changes that take place on the kick leg. If we think of kicking, we know we could do single leg bridges. We know that we could do resistive hip flexion there. We got the stretching. We got hamstring exercises. And then, like I said, this one right here, this is the exercise where we hold a leg, they bring it up, they take it out, and we're just putting them in side lying and doing a running motion, where I'm holding the leg for the stretch part, and that's their recovery leg, and the other leg is the leg that's moving, and they're able to control that stretch. If we look at sport-specific activities, again, you got to be looking at all those variables: range of motion, strength, flexibility. Activities should be geared towards the patient's sport and demands. Remember, begin with more basic movements, progress task complexity for athletes, progress to sport-specific activities, simulated competition, and full competition. For an example for you guys too, sprinting speed. These are just some ways of some papers that I came across with assisted sprints, resisted sprints, strength training, and some nice articles in the Strength and Conditioning Journal. Remember, the core is the key. I had this kid, he was a water polo player, Division I. Look at his paraspinals there. That's pretty good paraspinals. I had this guy that I worked with. There's no paraspinals there. And then this guy was a baseball pitcher, Division I baseball pitcher. So obviously it's a loaded question. Which person didn't have back pain of those three? It was the guy in the middle. Again, prescribing to, if what you have works at the right time, guess what? You get away with it. This kid had low back pain. This kid had low back pain and thoracic pain as well. So you could see sometimes having all of that surface dressing and all that muscle, unless it's working at the right time, it really doesn't matter. If we look at Running exercises, sorry for that video, but this is just form running on the wall, 1s, 3s, 5s. If you want to get the hip flexors going, this is a great way to get exercises. This girl is a Division I hurdler, but that's pretty good right there. She was about 4.5, 5 months post-op. This exercise right here, I don't know if there's going to be video. No, it's not working. And remember, lower abs for running, so pikes on the stabilization ball. This exercise is a great home exercise because what you do is you take a ball, a playground ball. You have them get a certain distance from the wall. When he's pushing into the wall there, he's getting hip extension, right? When he's holding his leg up, he's getting hip abduction. If I have him do clamshells in that position off of that ball, he's getting his external rotators as well. So I could put a person inside lying on a leg press. If you have a functional squat machine where you're at, which is it's an expensive piece of equipment, but what you do is you lay the person on their side, have them push through the heel instead of on the midfoot, and what you'll see is by doing that exercise, they're going to get an unbelievable glute burn. So you could do have them hold in those positions and do clamshells, but it's a nice way to just transfer it to home. If I look at jumping, okay, what can I do? I can do where they do squats with dumbbells and then rotate. Another exercise that would be good for golfers, but again, nice for jumping. And then this one, if you've ever seen this one, this is just basically called trainer haters. You go down, do squat thrust, push up, pull. You get a push, you get a pull. Back up to squat thrust, military push. You get a pull on the way up with the dumbbells. So you can have a person do 5 or 6 reps like this and they get their whole body done. So if a person comes in and they don't have a lot of time because they're running behind, they hit traffic, whatever. I mean, if they're at an appropriate point, you could do that exercise and hit everything. I threw this video in, or picture in too. Remember the football guy that couldn't rotate? This is what we did for him. We put him down on his leg so that he had to go through that hip to rotate. And what we did is we had this leg be forward, then we had it open up so that he would get external rotation on that hip, and then we'd bring this leg across and he would have internal rotation on that hip. And then that way it forced him to have to stay on that leg when he was doing his exercises. I could do the same thing for a quarterback to throw forward, side to side, whatever direction that I want. Plyometrics, we can see that Fred Wilt brought it, track coach. Plyo increased metric measure, and then eccentric muscle contraction. Remember, the big thing with plyometrics is that amortization phase. So the shorter time it takes from when you lower to when you explode off, that's the people that get the best result from a standpoint. So decreasing the time from overcoming gravity to going against gravity is the important part. There's some, if you're going to read any type of papers on stretch shortening cycle, Comey, Bosco, those are the names that you want to read it. They're pretty much landmark papers. The 3 components we talked about were loading, amortization phase, and then overcoming inertia. Remember, it's used in the final phases of rehab. Must have adequate strength base. They usually say be able to squat 1.5 times body weight to be able to do it. Probably a good indicator. And they shouldn't have any apprehension when they're doing it. Remember that progressions, if you look at NSCA and the charts they have out there, in-place jumps, you got jumps, you got hops, and you got bounds. So you go from 2 legs to 1 leg in that progression. Single leg effort, muscle, box drills, depth jumps. Depth jumps would be the most difficult to do, where you step off of a box and then you jump up on top of it because you're lowering yourself from a higher distance. We had the plyometric categories. So we had the jumps. This kid's like a ninja that does all of the videos for us. But you could see he's so light on his feet. Touch, touch, go, and then he lands it. Touch, touch, go, and then he lands it. We did this one already, and then this is just simple box jumps. If we look at sport-specific plyometrics, we showed this one earlier, but it's worth repeating because to do this, it's very difficult. You're not only doing a push press with the bar, with the heavy bar, but your feet are going in all the different directions to mimic a clock of Feldenkrais. So That's pretty hard to do. If somebody could do that, you could do that as part of circuit training for somebody where they're doing it 15, 20 seconds at a time, go to the next station, and then doing quick intervals for a minute and a half with 30 seconds rest. It'll get somebody in shape pretty quickly. A concept that's out there now by Mike Boyle, I think Greg Cook came up with this as well a little bit, but joint primary training need, ankle mobility, it's stacking one joint on top of the other, where one joint is about motion, the other one's about stability. Ankle mobility, and then you get knee stability. Hip mobility, and then lumbar spine stability. T-spine mobility, scapular stability, shoulder mobility. It makes sense. It's very elementary. It makes a lot of sense. And if you look at the progression in the process, you lose ankle mobility, you get knee pain. You lose hip mobility, you get low back pain. You lose thoracic mobility, you get neck and shoulder pain. Or you can get low back pain. Dick Earhart, who I had a chance to spend some time with, he always, when he treated neck problems, he never went to the neck. He always went to thoracic first to see what he could do with thoracic before he ever mobilized anything in the cervical region. So again, it all makes sense, but there's something that we've learned this weekend that sort of contradicts that a little bit. Where's the pelvis involved in this, knowing that most of the motion occurs acetabular on femur versus femur on acetabulum? The second thing is we've learned is that if you have a problem at the hip, it can affect the foot, it can affect the knee, it can affect the hip, it can affect the low back, it can affect the throwing shoulder and the pitching motion. So again, it's a nice concept, but know the limitation of it. I don't think it was meant to be anything other than to add a concept to make people start thinking a little bit differently. But again, know that it can go both up and down the chain. Just because you have ankle mobility issues doesn't mean that you're going to get knee pain. You could get it anywhere. The key points here is structure influences function. So remember, you're bound by what the structure of that hip joint is. Function regulates performance. So what your function is determines where your performance is going to end up. Performance, speed, masks, and balance. I see a lot of people that go out, and this is where the screening programs have become effective, because they slow everything down so a person could see when someone is weak on one side or doesn't have mobility on one side. Imbalance usually indicates compensation, and then compensation more than likely is going to be predictive of breakdown or poor performance. Take-home message again is about make sure you know whether it's the cause or the effect. Think proximal, think core, think boundaries, think link. And then there's some relationships between hip and gluteal weakness, lower extremity, some hip rehab sources for you. Phil already put that list together.